All right. Well, I'd like to get started. Thank you for attending today's webinar. We're going to talk about denial management, ways to reduce denied claims, and go through a PowerPoint and a little introduction here on what we're doing. To start, let's see. I am Craig Christensen. I got to add people to the waiting room here. Hold on. Let's get people in. Our company is H4 Technology. We were founded in Omaha, Nebraska. We were founded in 2012 and have been working with healthcare data for the past 8 years. My co-founder is Chris Henkenius. His history was with Nebraska Health Information Exchange and has consulted with 8 other statewide HIEs on strategic initiatives as well as data integration projects. What we are going to talk about today is the denial management. So we have a history of data management as a service. And so we have different modules. So we have social determinants of health, claims management analytics, financial analytics, population health, and whatnot. We're working with a variety of different groups. So whether it's critical access hospitals all the way up to statewide behavioral health resources, as well as state hospital associations. So if you're in Nebraska, you know we are the centralized data system for the Nebraska Hospital Association and helping them analyze market analysis and pricing information on their 837 records. I'll go through into the impact of the denials on the business. So nationally, we are seeing, an average denial rate in the U.S. around 10%. This can be higher in more Medicaid-funded populations. So one group out east, when we initially loaded their data, they're all the way up at, in the 13, 14 percentile range in certain areas. So from our perspective, the average denied claim is around $1,190, and the denied claim takes 16 days longer to pay. There's other stats out there that keep getting updated, but providers spend roughly $118 per claim on the appeals process. Additionally, we are seeing there's new reports on patient satisfaction and how the denials impact the patient satisfaction. So, this can be, from the patient's perspective, this could be seen as a breakdown or an issue with the provider or the facility, and could lead to the patient seeking care from another provider. We are all consumers in this world, and so if you had a bad experience, even if it wasn't the provider's fault, you might relate that to the provider. So we'll talk a little bit about denials. I think we're all aware of what a denial is, but the types of denials. So hard denials, this is where typically an appeal has to happen. Examples are no pre-authorization, not a covered service, could be a bundling issue, or untimely filing. Additionally, we have soft denials. This requires some follow-up by the provider. So pending receipt of medical records, denied due to missing or inaccurate information, coding or charge issues, pending itemized bill, pending receipt of invoice. And so these are all areas where you would need to require follow-up action or documentation to get it reconciled. We also have preventable. So these are hard denials resulting from an action or inaction on the part of the provider of service. So this could be registration inaccuracies, ineligible for insurance, invalid codes, credentialing. Even on the insurance side, there's, coordination of benefits or between 2 different insurance providers. We also see clinical denials. So the denial of payment on the basis of medical necessity, length of stay, or level of care. So denials of payment on the basis of those three areas. This may be concurrent, while the patient is still in-house, or they could be retrospective after the patient is discharged. And then there's basically a delay of payment where further medical or clinical action is required. I'll talk a little more on the medical necessity here in a little bit, but there was an interesting article from HFMA on, they were calling it a silent denial. Another area is technical or administrative denial, is a denial in which the payer has notified the provider by which of a remittance device with specific information describing why the claim or item was denied. So this is typically done via RARC code or reason code. Includes delay of payment where additional documentation is needed, maybe a coding clarification, or request for medical record. We'll dive into a little bit on this silent piece, but this is where medical necessity is denied for medical necessity, and we're seeing a conditioned response during the utilization review process. The top denials, typical top 10 denials, across the U.S., medical or duplicate claims, coordination of benefits, medical documentation, timely filing, authorization. It could be a referral process, ineligibility and verification, charge exceeds fee schedule. There could be modifier issues or medical necessity. What we are seeing, from our side is, duplicate claims are number one, with claim service lacking information as a close number two. So the duplicate claim process and the service lacking information could be preventable. This charge exceeds fee schedule has been a growing area where we have charges that aren't, there could be issues with the practice management system, reconciling, what the charge amounts are each year for the codes. The following other ones are planned procedures are not followed, services not documented in patient's medical record, coordination of benefits at 5%. And then we have a gamut of ones that I'm sure you guys run into. Patient can't be identified as insured, timely filing limits, prior authorization or pre-certification, charges are covered under a capitation agreement, expenses occurred after coverage termination, and eligibility and verification. So we have these denials, everyone experiences them. So what can we do to improve them, right? So that's the point of what we're trying to do. So what we recommend, and this is from working with our provider hospitals, is helping identify the top 3 denials across your organization, and then even breaking that down by payer, right? So we could analyze the past 60 or 180 days worth of claims, and then out of those claims, you want to set some baseline metrics for how to improve the denial rates. So we need to know where we are today to understand how we can improve, for tomorrow. With those metrics, we want to isolate those into each bucket, different buckets, different either denial reasons, and then identify, the biggest buckets, and easy wins. This can be used for setting attainable goals. And then, if you just, I think in anything in life, right, we get some easy wins, we keep the staff motivated, if we're working on a project, do some things that are to get you in the mode and method, and then expand from there. We also recommend, I think, using the 80-20 rule. 80% of the denials are usually, only 20% of the actual denials, and just targeting those big things first, as opposed to chasing, rabbit holes and getting caught up in certain items that might not be easily fixable. So once you look at your, breakdown of the biggest 3 denial reasons, then we want to dive into, drill down into those. So then you want to look at the RARC codes. So those are the RARC codes. Those provide more details and clarification on the denial reasons. You want to ask, is this same across your payers, or is this different by a provider? Look at that mix to see, if there's a commonalities between them or not. A tremendous resource is this x12.org. So they have definitions for all your denial codes, CARC and RARC codes. And they also have a search tool. I took a little screenshot there at the top, so you can search and look for CARC or RARC code combinations, modifiers, those type of things. So if you haven't looked at that, bookmark that and use that in your process. From the process improvement perspective, we need to identify a payer relationship. Oops, and that should be contracts. So, well, first off, the contact for your payer. Do you have a good relationship with that payer? Who's the contact person? And then we need to analyze that contract to make sure that that is indeed what is being, or is in the practice management system, and those rates and rules are updated. We should, a common problem we're seeing is in the registration process to get the updated information from the patient, whether that's insurance or other details of the patient added and updated. There's charge entry leakages that you could review. And then another process is the claims reconciliation. So this is identifying gaps where the claim that was sent out, and maybe it's the line items, what did the payer actually pay, what's still outstanding, and which line items are being are maybe incomplete, adjudicated, or being held up. And ideally, you have some of these pieces already in place. And so maybe through the claims clearinghouse, there might be claims editing processes. Maybe there's internal eligibility updates. Maybe there's a contract management system that helps you identify these gaps. And then, as always, usually there's some type of business intelligence layer that can help analyze the denials and where things might be falling out. When we talk about setting performance metrics, I found some of this information with a accounting firm on what the overall denial rates should be when you're working. And so good benchmarks, I think, or goals, right, is to look at your overall claim denial rate, at less than or equal to 5%. In the opening slides, we were talking about average is around 10, right? The denial write-off percent of monthly net revenue, getting that write-off percentage below 3, and then looking at your clean claim submission rate. So this is the first time when submitting a claim, if you can get 85% or greater of those clean claims going through. On those goals, those are KPIs, samples. We can measure and review the data. So you want to set a measurable goal. We talked about the clean claim rates. Maybe there's a specific CARC or denial code that you have a percentage and you want to reduce that. And so your baseline might be 12% of your denials are a billing error. You want to get that below. And then it could be maybe a days in AR calculation that you want to look at and average. Celebrate the successes and the teamwork that you're building out. That creates the best practices. You could try easy, fun competitions, and it's positive encouragement as opposed to the carrot versus the stick model. So we run through that process improvement and template, and I want to show you examples from Critical Access Hospital. So this was their line item charges by CARC. So the three biggest pies where charges are covered during capitation, patient cannot be identified as insured, and claims lacks information, CARC code 16. Generally, the CARC code 16s are, it was in our top 10. It was actually in our top 3, and so I wanted to identify that one. So this was claim service lacks information. We had 12.78% for around $23,000 in the sample. So we can drill into that remark code and then filter by, okay, what are the RARC codes for that 16? So we had 37% missing incomplete billing provider information. 27% of those were itemized bill statement, incomplete itemized bill statement. 14% were invalid drug code list, and so that could be updated in the billing system or practice management system. And then 6% were this referring provider number was invalid, and so or missing. And so those are all on the referral network and referral process that you guys own and operate. So the total impact just on that, CARC code 16 minus, the 23,000 hasn't gotten billed, right? 50-60% of that's recoverable, but just on the rework costs and the administration costs, so we had 122 claims. The average amount's about $118 to rework. And so we got a $14,000, a cost to rework those claims, plus then whatever's recoverable out of those $23,000 that are going to be billed. So the dollars just on that easy example add up, for that time period. And I think that was a 6-month time period. So you could basically double that over a year. So on those, process improvement, this is another example where we had the denials. This was some of the rework and recommendations we had. Services not provided or authorized by designated PCP. Use of this CARC indicates there's an issue with either referral, taxonomy code, or the services were out of scope of a given provider. We can go through some of these examples in a little more detail, but overall, down below, we have assess the internal processes and gaps for improvements, specifically eligibility verification process, demographics data and coordination of benefits, documentation of service, and then prior authorization of service. And so those are ways, you guys can use that within your own practice, for the benefit. So one piece I added this, I think late this week, just to, because of this HFMA article. So they're talking about medical necessity. They're talking silent denials from a conditioned response and utilization review. I thought it was very timely with what we're talking. The CARC code on that's 50. And so we'll send out the PowerPoint presentation so you can read all this, but silent denials often result from a case manager's effort to operate efficiently in the face of their many responsibilities, but basically the attending physician, it's a conditioned response to the information without actually, diving into it. And so you can read, it's, between the case manager and the attending physicians. As an attending, I didn't care about the UR. I just didn't have the time today. At my hospital, 1 to 2% care about the utilization review, and 20-30 are completely uninterested. So this is, I think, an area that could be improved. It's, obviously relationships between internal staff and case managers and attending physicians. But I thought it was an interesting article, and you can review that, and I'll send that out with the PowerPoint slides. So on the claims improvement process, we'll send you out this claims improvement template. And so we put this together when we're reviewing new customers. And basically what ended up happening is we'd load data and then have these analytical tools available, but they'd ask us, well, where should I start? What is the quote unquote low-hanging fruit that I can start looking at? So this is an example. We'll send out the fillable form that you can use. And then what we're doing is looking at the denials by payer for the highest denial percentage, the top denied CARC, 1, 2, 3, and the percentage. And then if you're working with us, we put the indications and recommendations behind. But you can see, once again, we took this kind of from an example, but we have that 16 code keeps popping up, right? And so the lacking information has billing errors, and this example is 22%. Then down below, we go through, okay, what, not by payer, but overall, what is our highest percentage of denials? And there we had the duplicate claims. So this example, they had capitation agreements and claim submission process. And then on that, on the top denial RARCs, so the reason codes, we had medical necessity needed updating, missing invalid occurrence. So documentation and claims entry should be analyzed. Our comment was it should have been caught by the clearinghouse, and then procedures for group billing not followed. So review this RARC by payer and assess why this is occurring. A new, service that's available, all on the denials. The previous PowerPoint slides were all about the 835 records. So the file that's coming back from the payer and how to analyze that and what you can do with that. Now we're talking about claim line reconciliation. So matching that 835 back to the 837 to determine if all claims filed with a payer have been processed. There's a couple different buckets that we look at, and one of those is a full denial. So the hard full denial. Maybe on a claim there's a partial denial, and so that's where, let's say we had 6 claim lines, 3 were approved or paid, and 3 were denied. And so that partial denial, and then an incomplete adjudication. And so we're able to look at the various buckets of those denials and then provide detail as to why those pieces and parts, and easily identify and group them by payer, by provider, date ranges. And then in all our solutions, we give you the claim line detail so you can research it and dig back into why things are occurring. These also allow you to monitor the payer performance. And so there's, if you have reports or dashboards to filter and monitor each payer back to the denial codes, and see maybe there's a payer that is denying a certain procedure code, and whereas the other payers are, that's not an issue. And so you can take that data and use those examples and take it back to your payer contact to understand and provide real world examples on what's being denied and why, back to the payer contact you have. Common things that we do is we group these denials on the missing, invalid, incomplete data, missing, invalid, incomplete data from submitted. Maybe the billed services aren't covered by the health plan. Benefit for the billed service is not separately payable. And then we found commonly that social services and some other groups that don't follow the common CARC and RARC code combinations. And so we created an outliers tab that shows, usually it's like I said, social services and other departments where, there's something wrong with what they're denying because the CARC doesn't match the reason code. So additionally, a newer service or item that we can help with is age trial balance information. So this is a variety of reports and dashboards by data service to build charges. We got different buckets by provider and by payer. We can also look at the build to payment. So when are you actually getting that payment? Is it within the first 30 days or is it more like 90, right? And that will all impact your cash flow. Data service to that payment. And then we have some benchmarks built in for the 12-month trend and year over year. So conclusion, I added this today, so sorry there. Addressing denials can be an extremely large project. You need to dedicate time and resources, to at the start. Payer requirements change frequently. I need to stay on top of changes to optimize revenue capture. There's significant return on investment, like we showed in that example, may be achieved. The ability to get the right people on your team at your facility to look at this in all areas of revenue cycle, make sure that they're represented to help out. And then create an environment of accountability. So if you set those measurable goals, actually measure them, month to month. Or over the quarter, and then provide the feedback to the staff on where they're at, and all those the wins that you get, help celebrate them within the internal staff. And ideally, let's start tracking those denials as soon as possible, because every day claims are coming through that are being denied, and there's opportunity for you guys to recoup some of that revenue. So, okay, so that's our presentation. I can jump into a brief demo. I wanted to stop here and see if there's any questions specifically on what we presented on. And otherwise, I'm recording the presentation as well as we'll send out the slides and provide some follow-up documentation like that x12.org site. Anyone have any questions?
Greg, I've been monitoring the chat. There's no questions in the chat, so.
Okay. Okay. I'm going to jump into a quick okay. To show you what we're doing here. Refresh this. So just real quickly, on what we're able to show when we're getting the 835 records. So for example, in 2 states, we partnered with the hospital associations, Nebraska and Indiana, to offer the 835 denials management platform and a partnership with them. So up top, we have a variety of filters by time frame, service date range, payer names, provider names. And then we look at specific procedure codes, DRG codes, and then we have denials and reason codes and procedures, all filterable. So for this example, we have data from earlier in the year. We have roughly $89,000 of denial claim lines, the total number of denials, and then I can see kind of by week, where is there an uptick in my denials. From there, I can easily look at the payer mix. So I have a certain percentage of denials in each bucket. I can hover over the graphs and see the capability and the total percentage and total dollar amounts. On the right, on the procedures, I can also see the count. So is it, one large group, one large procedure that's being denied, or am I getting, death by 1,000 cuts here, with 59 of these, maybe at $100, right? And so I can easily analyze that to see what my denial percentages are and what's happening with that mix. And so from here, these are the line item charges. So these are the denials. So overall in our demo here, we see exact duplicate claims. This follows just exactly what we talked about. We got benefit for the services, including a payment allowance for another service. So that's a bundling issue. And then patient can't be identified as insured. And so we have the, as you hover over this, you don't have to remember 31 is patient can't be identified as insured. We got the reference tables from the Washington Publishing Group updated in this tool. And so it'll tell you exactly why things are being denied. So let's look at the 16s. So we got a group of 16s. So up here, you just go to CARC code 16, apply the filter, and then I can see, okay, of that, I got, here's my payer mix for those denials. Here are the procedures that are being denied. And then here's the reason codes for why these are being denied. And so I can see, okay, I got missing, invalid, incomplete, national drug code. Talked about that in our other example, billing provider, taxonomy, diagnosis or condition. And so you can dive into these and further filter and then actually look down at, okay, here's my top 20 patient claim lines that are denied. And then here's actually the detail of those denied claim lines, claim lines. So I can look at either maybe it's a modifier issue, maybe it's other data elements, and I could go back to my practice management system to resubmit that claim. So what we're able to do is just provide a overarching overview of what's happening with the denials and let you drill down into that to fix and monitor as the payer, payers change the rules quite frequently, and what's going on today might not be the same as the start of the year or as last quarter. So this just allows you to monitor those and easily identify areas to recoup some revenue. So. Okay. I was going to see any questions. All right. I'm going to conclude the.
Hi.
Hello.
Go ahead.
Hi, this is Nancy Costello. I have had nothing but technical issues throughout this whole thing, and so I missed seeing most of the slides, and I missed part of the audio. Did you say you are going to be sending out the slides and a recording of this?
Yeah, yep. I do have the slides. I'll send out after the meeting, and then I did record it through Zoom. It'll take me a little bit to get that over to a spot where I can publish it. But yeah, I'll send that out. And if you have any questions, we can always do a follow-up discussion. 15 minutes to
Great. Thank you so much.
Okay.
I really appreciate it. Thank you.
All right. Well, thanks.
Craig, there's just a couple things. One, I just put in the chat that all the data that you're looking at, and depending on how you want to sort it, you can export it into an Excel spreadsheet, number one. And then number two is typically when we bring a client live, we get year-to-date data on the 835s. So we have 6 to 9 months worth of data, just depending on when you come on. We can also pull in the previous year's claims data, but then we also get the 837s. So if you, let's say, identify a problem in your denied claims, you can look at what the reason for that is, correct it in your practice management software or with your clearinghouse, and then you can monitor those claims through the 837 going forward to see if those corrections that you put into place actually did happen. So I just wanted to share a couple things there.
I appreciate it, Tony. Those are good information. So, well, great. Well, I'll let, if there's no other further questions, I'll let you guys get back to your day. I'm, once again, here's, my contact information. Feel free to reach out. If you have questions, we can dive into your specific information or maybe your denials and what's happening at your facility and just have a discussion. So we're open to that. I would love to talk to you, and thank you very much, and have a good day. Have a good Halloween weekend.
Thank you.
All right, thanks.
Bye-bye.